Welcome back, and we move on now to item 7, which is the Integrated Performance and Quality Report, and ask David to orchestrate this section for us.
Thank you, Boyd, and good morning, everyone. You should have a copy of the both the SBAR and the Integrated Performance and Quality Report for July. And as previously discussed at the last board meeting, we have now got this back in synchronisation that the individual elements of the report go through the subcommittees first before coming as an aggregated report into the board meeting today. You'll notice that the recommendation is for limited assurance on the integrated report. I think we've spent some time already talking about the challenges that we have both around scheduled and unscheduled care, and that is reflected in the performance, and that is the reason for that recommendation. I would say that the issues that are being addressed through that have already been alluded to as part of our annual delivery plan, which is in its final stages of completion, and the board will see that on the next meeting. And from that, you should be able to, I would suggest, take assurance, further assurance and better assurance in terms of our trajectories and our way forward. I should also add that as part of the Financial Resource and Performance Committee, it was approved in the last meeting a new performance management framework which will sit around this report as well as our overall performance, and again that should give further assurance in terms of the oversight and management that will be provided as we continue to work and improve our overall performance. I want to talk about the individual items. I will allow you to come in as you wish. You know, it's not all bad news, I can assure you. There is some really welcome efforts by all our colleagues to deliver the performance that you see there. And there is areas of performance improvement. Tim mentioned vaccination earlier. We did have some extensive discussion around cancer performance the last time around, and as we said, then we expected the trajectory or the downward trajectory in cancer to come to a stop, and that has slightly recovered, and we anticipate that to continue, and that's because of the time lag in some of the activity that had been previously interrupted. Also, we've seen some improvement around freedom of information requests, where government were putting us under very close scrutiny in terms of our turnaround time, and you'll see that there's a significant improvement around that. One area that I have to make apology for is around falls and infection prevention and control. Some of the data has been corrupted, and therefore I would ask you to ignore that section for today, but we will update that, and we will send out a separate update prior to our next board meeting. So within the next couple of weeks, we will get you something that is reflective of the true position. So if you can ignore that in the meantime, that would be appreciated. So I'm happy to open it up for questions, and my colleagues and I will do our best to answer them. Susan.
Thank you, David, and thanks for this information, which is getting clearer all the time that we look at it, and good to see that it's now aligned and we can follow it through the process. I've got a question, page 115, about the delayed discharges, which is obviously something we discussed in Pam's opening remarks this morning, how important it is to us. And I wonder if you could help me understand what's behind some of these figures. Is it how many new people are being added to this? So what's the churn here? Are there some people who've been individuals who've been represented in those figures for several months, or are they all new people? Are we building up a bigger problem here? Do you see what I'm saying? I mean, that one figure doesn't really tell me what the issue is. I'm sure you know that, but it's just the picture here isn't complete for me. Thank you.
Yeah, I mean, just in the headline, and then I'll maybe ask Louise to make further comment. Yeah, it can be often thought that this is the same people who are on this list. It's not. So it is. There will be some who have been delayed for some time for particular complex needs. But actually, this is a timing issue in relation to that. But Louise, did you want to add any more?
Yeah, absolutely. Sorry, my unmute wasn't working very well there. There are a number of people that are on the list that we are really struggling to place because they need highly specialist support, or they are waiting for a particular place that isn't available at this time. So there will be some people that are on that list for much longer than we'd want them to be. But equally, as you rightly say, there is flow on and off the list at any given time. And the last time I looked, it was usually around about 10 people a week, sometimes more, sometimes less, that will move on to the list, will move off the list. The aim, obviously, is to have more people coming off than going on. And we have done significant work on that in terms of how we support people going into Regmore, for example. So our social care staff go into the wards, spending time there and really trying to encourage people to be off the ward as soon as possible. So there is a mixed picture of people that have been there for a long period, people that have moved on and off, and maybe only on the list for a few days. And it may be as we get better with how we use the data, we can show people that have been on for more than a month, less than a month, etc.
Thanks. Fiona Davis, did you want to add anything from an Argyll perspective?
Yeah, thank you, David. And thanks for the question, Susan. I think in Argyll we have a similar picture. Our overall delayed discharges, as you'll see later in the report, are a smaller proportion of our number of people that are using our hospital services. And the vast majority of those are on our list for a very short period of time as arrangements are made for a package of care example to enable a safe and appropriate discharge. So a small number of the delayed discharges in Argyll and Bute are more complex and delayed for weeks rather than days, but it is the minority of cases. The vast majority are very short term. But again, like Louisa, I'll be interested to see if there's a way that we can present that information so that the proportion can be monitored and is transparently available.
Thank you. I was just thinking, I think maybe we are missing something here. You know, we maybe could present it in a way that shows more of the true picture. If the majority of people are there for, like we do for the cancer, the 30 days, the 60 days. I mean, all waits are not the same, and we don't want anyone to wait a day longer than they need to do. But is this picture showing us or giving us enough view about where the real problem are, where the real delays are? Thank you.
Thanks, Susan. I think it's a good question, and we'll have a look at trying to present that for the next time around. That might give us more information. Thank you. Alistair Christie.
Yeah, thank you, David. Just looking at the waiting times, I really like this whole report, but I'm not actually sure for the sheets that sort of in 117 that we've actually got it right. We can see the trend in 117 of the waiting times, and then we've got the detail underneath. But presumably, presumably that some clinical conditions it's more serious to wait on than others. So therefore, I don't know, pick one, perhaps dermatology or something that it's not perhaps the end of everything if there's a bit of a wait on that, but on others there is. And I can understand why the removal of the orthopedics. However, just in the election campaign that I personally been through when speaking to about 2,000 people, I met an awful lot of people that are outsourcing their own private care for orthopedics for operations, especially hips. And what we're not getting a view from on this, if you take it that I suppose a lot of the orthopedics are for older people. So if there's 2,400 people waiting, that's quite a high percentage of the older people in Highland with the condition. And I'm not sure that we've got, David, the information here to understand whether we're really turning that tanker on orthopedics or not. And the other point I want to make is on the cancer waiting times. I take your point that it started to actually turn around now, which is good, and it's really to get some assurance or information as to when we might be back at the fantastic levels that we were at previously, you know, earlier in the year, especially for the 31-day target, which was a phenomenal achievement, and my thanks to all the staff associated with that, because that really was a remarkable achievement. So when do you think we could start seeing a return to that sort of level? Thank you.
Thanks, Alistair. I'll answer the first part of the question and then maybe ask Catherine to make comment around the cancer services. In terms of the orthopedics part, that was the reason for that was merely from a presentation point of view. It was so that if we added orthopedics onto the chart, all the other bars would appear very, very small. So we recognise that orthopedics is indeed a major challenge for us and will remain such. Hence the reason of National Treatment Centre coming on is so critical for us. That adds capacity around there as well as ophthalmology. What we will do, and from a governance point of view, through the finance, performance and quality report, as well as is in the subcommittee, is to be able to show our activity that we are planning, which also then will impact on our trajectory. So that recovery plan that Catherine alluded to earlier on in the meeting is going to be critical for us to be able to plot our recovery along with our activity. So that really will answer that question. But Catherine, can I invite you to add some additional comment?
Yeah, absolutely. And so I'll come in on the cancer question. Alistair, thank you for the question. The situation with cancer is that, as you've noted, we have made significant improvements in terms of our cancer delivery. Over the timeframe that this report relates to, we were seeing significant absence that hit our endoscopy service, which is our diagnostic part of the cancer pathway, and that reduced the manpower that we had available to deliver. We also had a colleague leave us, and we have taken action to recruit into that post, but we've also taken action to go through a tendering process to deliver diagnostics now through independent sector activity. So there's a lot of work going on to resolve that, and that will immediately impact on our cancer performance, particularly around the surgical pathways. We also have significant impact. We've had a colleague that was not with us, one of our surgeons, for a period of time for breast surgery, and breast is particularly a pathway that we've been challenged with, which is disappointing, because previously, as you know, we were challenged through our urology pathways, and a huge amount of work has gone in to applying the Scottish Access collaborative targets and different ways of working that I've described to the board previously in relation to the way the management team manage the cancer patient pathways. So we are currently in the throes of putting in a breast recovery programme so that those patients that are waiting will be seen faster, and we'll be able to deliver the requirement to those. And we do anticipate that we will be in a significantly high performing position once we've put those interventions into place in terms of our position for cancer delivery across Scotland. I hope that's reassuring to you, Alistair.
Good, thank you, Catherine. Alex.
Yeah, thanks, David. Couple of comments and then a kind of question. First one, I think it's great that the psychological therapies and the CAMs are getting better and getting closer to the target. I think that's something that should be applauded and great to see that happening. In terms of how this is being used in the public, I sometimes read the Courier, which is from my old stomping ground of Dundee, and DC Thomson have got a banner headline about they're doing all this analysis of what's actually happening in NHS Tayside and Fife. And clearly what they're actually doing is they're just lifting the Fife and Tayside IPQR data, because it's very similar to this, but they're using it as if it's their analysts that are doing it, and they're focusing purely on what's not good. They're not saying anything about the positive side. Now, if DC Thomson are doing it, I'll guarantee you the P&J are looking at it, and that's something else that needs to be considered. So this is very useful, but I think Fiona needs to think about bearing in mind how some areas of the press are starting to use this data, because, as you say, quite rightly, Phil, it's for the public. So, thank you.
Thanks, Alex. I mean, I recognise what this dashboard and this report should do is provide a context of a number of our performance areas, and by definition, there will be some areas that will perform better than others. And for those who are waiting on those services, then we do recognise that they are suffering through that. So you know, we are striving to make improvements across the board and recognise that the ones that we are performing least in will be exposed. I think that's just the nature of those things, but we're aware of it, and that's why we, in our annual delivery plan, will be setting out plans that will address those as quickly as we can, recognising too that some are more difficult to solve than others, and some have been around for a long time. But yep, that's the nature of the job, unfortunately. Thanks. Bert.
Thank you, David. A couple of queries and a comment, perhaps, both in relation to staff turnover. So I'm interested just to find out a little bit more about the plans for flexible retirement. Is this something that will be a new initiative? Is there a demand for it? And do we think that it is going to make some kind of noticeable difference in terms of staffing levels? My other question is in relation to the posts that are likely to be taken up in the NTC. And I've spoken about this before. The NTC is a hugely welcome initiative, but it will bring with it a demand for staffing. Do we have any idea of what the likely impact is going to be in terms of the numbers of staff that are needed, where we think these staff members are to come from? I am aware of a national recruitment initiative that is underway, but I am also aware through speaking to staff that quite a number have an interest in working in the new NTC. So I think it is something that clearly has to be borne in mind, and obviously the paper tells us that. But I'm just interested in what we think the likely impact of that is going to be. Thank you.
Thanks for your question, Bert. Fiona Hogg, can I invite you to respond, please?
Yeah, absolutely. Thank you. Yeah, and so with regard to the flexible retirement, we have agreed an approach around that. I suppose in thinking about retirement, there's sort of a couple of different scenarios, and what a lot of the policy that was approved is about is the process that we follow when someone wants to take their pension benefits, but not necessarily leave the organisation entirely. And so that's one of the things we've been progressing, is to understand how we can be more proactive around that, rather than people having to leave and come back and apply for another role, putting in place ways that we can discuss ahead of time and proactively what sort of hours and position might somebody wish to move to as they begin a sort of phased transition from sort of full-time working into sort of partial retirement. So that's been really helpful for us to be able to put that into place. But it really is an extension of the flexible working policies that we have. And that continues to be an approach for us, because we know the impacts of having an ageing workforce and of the pressures of the pandemic mean that a lot of our colleagues are looking for alternatives to sort of working full-time, working long shifts, working in fully clinical roles. But actually that's a huge opportunity for us, because there's some real expertise and experience there that it might not be in exactly the same role that people are in at the moment, but working with people in a proactive way to identify where they'd like their career to go over the coming years is being enabled by that flexible retirement policy. But a lot of that is also about, it comes back also to local workforce planning and staffing conversations and dare I say, performance management, appraisal and development conversations, where each manager understands exactly what the aspirations and desires and plans of their colleagues are, so that can help us predict. Because I think our biggest sort of defence against some of the challenges we've got is being able to gather intelligence ahead of time of what people are wanting to do and trying to work with them to find good solutions that meet their needs. So that is an ongoing piece of work for us, but we've definitely made significant progress over the last few months in getting approval for a slightly different way of working. In terms of the National Treatment Centre, and I can't see if Debs is on, no, but I think it's we had the project board for the NTC just earlier last week. The recruitment for the NTC is actually progressing very well, and I can't off the top of my head remember the percentage of posts that are filled, but all of the key senior leadership and specialist posts have been filled, and we're now working through some of the more volume roles. So of course there's always pressures in any kind of recruitment. A large number of the roles at the operational level in the treatment centre will also be filled on a rotational basis. So that what that means is that people will spend some time in the National Treatment Centre and some in our other settings, and that's both from a practical perspective of people being able to have a good range of opportunities to use different skills in different settings, and to make sure that we're as the treatment centre will be an integral part of NHS Highland and its service delivery, that actually we will be very conscious to make sure that we share those skills that we have across the piece. So it's definitely something that is giving us, we've got good attention around this, and actually some of the work that the National Treatment Centre has been doing is helping us with our broader recruitment in terms of the campaigns and the marketing. We're about to move into having some adverts on Underground in London and on buses in Glasgow and Edinburgh and some parts of the Central Belt to really promote careers in NHS Highland, and I think that includes the National Treatment Centre, but it's actually really giving us an opportunity to promote ourselves on a larger scale and attract a wider group of people. So hopefully that's a helpful update, Bert.
Fiona, and I think the other added benefit of that rotational element of staff is that good practice that is developed and adopted within the National Treatment Centre can also then be used and brought back and into the mainstream elements associated with Rigmore. So hopefully the services will be able to work side by side in a very positive way and be able to continue that journey of learning as the NTC comes on board. Let me come to Joanne and then Anne.
Okay, thanks, David. It's a bit of a reverse back to the slides that Alistair was discussing. I just wondered if somebody could explain to me from slide 117 to 118 why there's a difference in the figures. It looks like we've either we've added patients or lost patients between the graph of the totals and the graph of the specialities, and it's the same for 119 and 120. Thank you.
Okay, I'm not seeing those gaps that you're referring to, but I'm more than happy to have a follow-up discussion around that. Do you want to give some specific examples, and maybe Lorraine or I could try to answer them?
So if you look at graph 120 on page 120, the total's 19737, and if you go to the overall, it's 19561. I'm just wondering what the difference is where the people have gone, and it's the same on the two above. The totals don't match.
Okay, Lorraine, do you have any comment associated with that? That's the total at the bottom of page 120, and what then shows in the commentary related to the graph.
Sorry, David, which
Page 119.
but the heading, please.
Yeah, so it talks about total on waiting list, ongoing waits 19561 above the bar chart.
Sorry, I'm looking at the IPQR itself. Do you
Yeah.
want me to pick that up separately? Because I'll look at the numbers and I can get back to you.
Yeah.
Okay, thanks.
There's a slight difference of 100 or so patients on that, but yeah, happy to look at that, John. It might just be a way the part's being extracted. Thank you. Anne, can I come to you for your questions, please?
Sorry, David, having trouble with the cursor there. So I think my question's a sort of broader one about our approach to the IPQR. So I noted that we're going to review the IPQR in relation to the strategy when it's finalised. Obviously, we collect a huge amount of data on an ongoing basis. So there's many more indicators or targets that we have and we collect data against than are presented here. So I just wondered if you could say a little bit, Lorraine, about whether you expect the content that we're seeing today to change markedly once we finalise the strategy and review the IPQR in relation to that, but also what our approach is to deciding which indicators and targets we present in this overview report. Is it ones that we are particularly challenged over? Is it ones that we can compare our performance with nationally? Is it a combination of a whole lot of things? It would be helpful if you could give us a bit of an overview of how that's arrived at. Thanks.
Thanks, Anne. Yeah, I think that we're obviously aware through the board development session that we've got our 16 outcomes and they all cover that age range. And I think that we have got some areas where we don't report at all that the board might wish to see because they're really important for achieving our strategic objectives. We don't currently report anything on maternity services, for example, and that might be an important area that we'd want to report in the future. So what I'll be doing is working with the chief officers and Heidi, and maybe not you, Heidi, but Heidi and Boyd, to look at the key indicators that would give you assurance from a clinical perspective or from a professional perspective, or indeed in line with our strategy, and come back with a proposal about what that looks like to give that oversight, and equally looking at what we need in terms of further information that Louise and I have been working on from a community and social care perspective through that performance framework to get and I think it's important that we look at that flow of information as well, so that we're creating that stories, I guess, for communities and what's going on in their local area, as well as the overall board picture. So it's definitely a work in progress, Anne.
Okay, but that's helpful. So just for Alex information, the P&G already has. If anybody read it yesterday, there was a Grampian and Highland version of what you read in the Courier, Alex. Yeah. Anyway, thanks, and obviously I look forward to discussing how it might might change as we go along. For example, I'm aware that we're under particular scrutiny at the moment in relation to the drug and alcohol MAT standards. So I was thinking that might be an appropriate one to scrutinise somewhere.
Yeah, I agree, Anne, and we've got some quality improvement work going on in there to get I guess, a clearer understanding of what that looks like, and absolutely would be reporting that one in particular. So I agree.
Thanks.
I think there's it's an opportunity for dialogue around this. I think it's multifactorial in terms of what goes together to make up the judgment around what we include within the report. But you know, I think it's incumbent upon the subcommittees also to have a major influence on that for their respective areas. And indeed, it's within their scope to be able to say we would like this particular metric or that particular metric that we've reviewed to go to the board. So and equally the board as a whole has the opportunity to say I would like to know more about X, Y, or Z, and we're more than happy to provide that. It will no doubt continue to evolve, and equally we also want to try and make sure that the data is clear. So some of the items that Joanne raised earlier, happy to take that feedback, and we'll look at how we can make sure that data is more clear for those who are reading it. And well, it'll never be perfect, but we will, through dialogue, hopefully continue to improve it so that it denotes what our clear position is. Are there any further questions? I know we talked about performance quite substantially at an earlier part of the meeting, particularly around scheduled and unscheduled care. But if there are no further questions, I would hand it back to Boyd. Thank you.
Thank you, David, and thank you to yourself and to Lorraine for all the work that goes into this extensive amount of preparation of data for us. And obviously it's a work in progress, and there are continuing ways of improving it and extending it, as you've already acknowledged and as people have suggested. So with that in mind, and you have proposed a limited level of assurance being at a work in progress level. So are we content to note the IPQR on that basis? Yeah, thank you. And can we move on then to the finance assurance report, the month 3 position? Dave, are you going to speak to this?
Yes, I am. Thanks, Boyd. I think for the 3rd year running, we're facing a year of uncertainty and complexity due to the financial position that faces all boards. And this year we've also got an increased level of scrutiny from government as well, in terms of looking at the position from a national position as well. So hopefully that scrutiny though will help to clear up some of the uncertainty and complexity that we face as we try and resolve issues as the year goes on. So the position we've got in Q1 really includes things that we are certain around, and doesn't necessarily include things that we have not yet got a degree of certainty about. So hopefully the position at month 3 will improve as the year goes on. So Q1, to remind members, the plan we submitted to government for 22-23 initially had a £42 million gap. Now that gap at that time was already mitigated by £15 million of assumed resource that was going to become available from previous year's allocations to get that £42 million. We allocated a challenging but we felt deliverable cost improvement target of £26 million, which left £16 million of a gap which we assumed would be covered by brokerage as we had done in previous years. However, after the plans were submitted nationally, government advised us that due to the national position, that boards should not be planning on brokerage and should plan to deliver break-even. So £60 million of a gap still remains an issue that needs to be resolved in line with all boards who are facing a gap at this point in time. As well as this, we were also advised by government, the Treasury had advised them of no further COVID funding being available in the current year. Now, the plans submitted by boards assumed that all COVID costs would be funded, and we've had to revise our assumptions around that one. So, as it stands right now, we initially submitted a £31 million COVID plan. That's been reduced, mitigated, managed, and refined really with more information, as Tim mentioned earlier on with the vaccination programme, down to £24 million, and we've got indicative funding of 20. So we've got a £4 million problem in terms of COVID. We've got a £60 million gap that we haven't got a methodology of funding yet, and we have a £26 million savings target. So it's a very challenging year, to say the least. So the position as at Q1 is showing an £11 million overspend against budgets, and a projection at this point in time of a potential £33 million overspend by the end of the year. Now, the development session for the Finance and Performance Committee, we're going to have a look in a bit of detail of in terms of the Q1 position. So that's been scheduled for August to have a bit of a deep dive, and we're also having some financial scrutiny meetings starting on Thursday, with the Highland Health Social Care Partnership, and the following week with Acute, to actually deep dive the financial positions for each of the operational units. So I'm not going to go through the sections and tables 2 to 6 to a huge degree of detail in this meeting, Chair, unless you particularly want me to. But in those sections, it highlights the operational performances and details a whole range of issues that are impacting the financial position at this time, and highlights in a bit of detail some of the more significant things that are materialising as the year goes on. In terms of savings, we have a pipeline of potential savings of £12 million. That's the unadjusted or non-risk adjusted pipeline. In terms of the forecast for the year end, we've assumed slippage on savings at this stage because we don't have a pipeline to deliver of £12 million or £12.5 million within that overall forecast. So it's simplistic and probably too simplistic, but the easiest way to think about the financial position for Q1 is we had a gap of £16 million. We've got £12 million of savings slippage, which is 28, and we've got a £4 million problem in COVID, which is 32. So those three components are the big chunks. Now, it's not as simple as that, as you know, and the financial position is a potpourri of different cost pressures and all over the place. But the three main items that are affecting the financial position at this time are those. As I mentioned, we've got some financial performance meetings set up with the operational units. The PMO continues to look at cost improvement opportunities through the Financial Recovery Board. And as well as that, we also have a range of national initiatives being driven by government. Alan Gray, who is the previous finance director at NHS Grampian, is seconded to government at this point in time, and he's leading in a range of recovery scenarios that the boards are working together at both chief executive level and finance director level, looking at ways of national initiatives that might improve the financial position. The other thing that we haven't actually played into the financial position at this point in time is you'll be aware that we had some resource allocated to us late in the financial year last year, which other health authorities, health boards were able to pass to the IGBs for them to carry in IGB reserves. Excuse me a sec. As you know, health boards can't carry those reserves, and we don't have an IGB in the Highland Partnership area. So we allocated some of that money back to government, and some of that money has been held for us by the Highland Council in an IGB type arrangement. So we've got £29 million sitting with Scottish Government, and £16 million with Highland Council, which is £45 million. But that, first and foremost, must finance our COVID costs. So the first column, COVID costs, are there. Plus, there are a number of ring-fence allocations. Government is looking at all streams of money, including those monies allocated to last year and including those monies allocated this year, to look towards what financial flexibility we can use in the current year to help us get through this year as a nation, like in Scotland, as we look to in the longer term for the following year onwards to look to transform and reshape services to allow us to live within our financial means. So there's a lot of uncertainty right now in terms of how much of that money will be able to be mitigated against the financial position bottom line right now, and how much of it may or may not be. So we're hoping to get some clarity and certainty in that as we move into Q2, and hopefully report an improved position moving into future months. I think it's important to say that we're not outliers. Speaking to colleagues in other health boards, we are certainly not in any way an outlier in terms of our financial position, and it is a national trend, which is a result of the pressures that have materialised through the pandemic. There are still some risks associated with the position that we have not played in yet. There's a couple of significant areas. One is the agenda for change or pay rises in general, actually. As you know, right now, the offer that's been negotiated with unions around a 5% uplift for NHS agenda for change staff is currently not being accepted. Our financial plan assumed a 2% uplift. Government have advised us that any uplift will be funded, but of course we have to wait to see the detail of how they apply that funding as to whether or not it's cost neutral across all boards or whether there's any risks to individual boards. For example, if it's applied on an NRAC basis, NRAC funding might not match what we get in terms of our staffing model, particularly in Highland, where we have social care workers and agenda for change terms and conditions now. So there's always a risk around that. And the other risk, which faces all of us in our lives, never mind just NHS, is the cost of living and RPI and the rising prices of energy, of fuel, and most things. We're facing price rises. We built assumptions within our financial plan at a point in time, and clearly it's the position is getting worse, and we need to be very careful about monitoring how much the cost of living or the RPI is impacting on our bottom line as the year goes on. I wasn't going to say much more, but happy to take questions. As I said, the detail will be scrutinised at Finance Committee, and I didn't want to go into too much detail at the board. Happy to take questions.
Thanks, David. Other questions for David on his report? Anne.
So complex and challenging, David. So without getting into the detail, because as you say, we'll have an opportunity to scrutinise that in committee. I wondered if you could give us an indication as to whether this picture you would characterise as cautious, realistic, or dare I say it, optimistic. I'm wondering, for example, if it's usual in this first 2 or 3 months of the year for operational spend to perhaps be significantly more than it might be later in the year. You know, fresh year, you know, fresh budget, perhaps. I don't know if there's any kind of, you know, picture that's typical for our spend across the year, and whether this is within that normal picture or out with it. So, you know, I wondered if you could give us any impression of that. The other question that I had, the thought that's in my mind is, I suppose, the extent to which we may be asked to contribute to the national picture in terms of the monies that are being held by Scottish Government. And I guess my concern is that we will have very little opportunity to support the kind of transformation that we know is required if we are to address the performance issues that we've been talking about earlier in the meeting. And the focus will be entirely on the national bottom line, which is understandable, but you know, that's, I guess, not what we need in terms of our strategy that we're hoping to agree in September. So I wondered if you, I know that's a rather large question perhaps, but I wondered if you could address both of those things, particularly in terms of how we might be able to preserve some investment for transformation. Thank you.
Thanks, Anne. I mean, I think I'll take the second one first, if that's okay. You know, government are well aware that we are constrained in a way that IGBs aren't because of the legality that they're set up under, and their offer of help in terms of carrying money for us was due to that fact, and I would be very, very surprised if that was then became a disadvantage to us, that other authorities and health boards have access to monies that were then prevented from having access to. So I would really rate that risk as very low, to be honest, in my mind. The second one, where does the financial position sit? I would say it's balanced. I think right now it's difficult to interpret sometimes, because if you look at, I know you asked the question of Elaine, if you look at adult social care position right now as an overspend, but we know we've got money that we can apply to adult social care, but then we need to look at other things that we wanted to do with that money and get a balance on that. So money we know that we will be able to play in the position that isn't played in yet. But similarly, we do have all those pressures that we've mentioned, pay and other pressures on the unit. So, and it is a significant overspend to have in Q1. But we've been analysing the financial position really, really closely over the last couple of years because of COVID, that we had such a handle on where those numbers were. So I think it's balanced. I would say it's not certainly optimistic, and I certainly wouldn't say it's pessimistic. So I'm hoping it will improve.
Thanks, Anne and David. Jerry, followed by Alex.
Thank you, Boyd. It's probably more an observation rather than a question, although I'll probably use a question to highlight my observation. I think one of the big challenges here in terms of, and I know David's proposing limited assurance, which I think is the best we can do at the moment. But certainly one of the things that strikes me is the number of variables which we appear to be dealing with is not getting any smaller. Normally you expect as you move through the year, even at the end of Q1, that some of your planning assumptions can become fixed, and you've now got some fixed points. So if I use the example of COVID funding, and looking at paragraph 8.1 of the report, I think when we spoke about the financial plan, we had £23 million, which we carried forward, combination of Scottish Government and Highland Council, but potential spend of 32 million. We'll brought our spend down to 20, what does it say, 20, just under £24 million, yet we still have a £4 million gap on COVID, which implies that some of the £23.2 million is perhaps not available for COVID. It's getting utilised for other things. And I don't need an answer to that question, because that will work its way through. But I think it's really just to highlight the variability which is still in the system. And we've really got no fixed points at the moment where we can continue to move on from this. And I think it really does cause significant cause for concern in terms of where I'm pleased to hear David say that the £33 million is a balanced position, but I think we have to be aware that 33 million could escalate fairly easily given the range of risks and given the range of variables that are still in the system.
Thanks. Yeah.
Thank you.
You're absolutely right. And the other, another variable that we haven't got in the plan anyway is what Pam and Catherine were talking about earlier on in terms of the letter we've received from government around waiting times, etc., and what funding we'll get for that, etc. So there are a multitude of variables, and they're significant variables. You're right about that, absolutely. But similarly, we do have resource banks which we can use to a certain degree. So I'm still unbalanced.
Alex.
Yeah, thanks, Boyd. Yeah, Dave, we talked a little bit about this in the FRP earlier on, but the thing that does concern me in terms of the additional challenges, we've talked earlier on in this meeting about the operational challenges, the treatment time, the performance challenges that we have. When we looked at the financial savings 3-4 years ago, we got grip and control. We put pressure on people to do that, and it worked. Then COVID came along, and we took grip and control quite rightly off because it was a matter of we've got to get things done. How easy or difficult is it going to be to put that grip and control back, bearing in mind that we've now got all these challenges for the performance side of things, as well as the financial challenges? And is that a risk that you factored in, or is that something that we need to put on to the risk register?
I'm not sure whether it's something for the risk register. I think you're absolutely right. We had definitely a culture change in result because of non-pay and pay grip and control, particularly non-pay to a large degree, and then we basically allowed people to basically sort out COVID and not quite spend as they wish, but the controls were certainly relaxed significantly, and it's getting that mentality back into people's day-to-day operation. I'm mindful as well, last time I was asked this question, I'm also mindful that took a tremendous amount of effort from people who are supporting us in delivering what we need to deliver. So procurement, for example, it took a huge amount of effort for all the orders to be consolidated into a format that allowed us to scrutinise them. Then managers are sitting till early evening, go through every order on a line-by-line basis, and scrutinising those, which had an impact. I do wonder whether this is the right time to do something like that when people are really, really busy. And I guess for me, and the challenge I'll be giving to I guess to Louise and Catherine as finance director and to Fiona is that's what needs to be done in these financial scrutiny meetings, and we need to hold people to account downwards for their budgets. A little bit more than we probably have been doing for the last couple of years, and that's the first place to go. But I think you're right, Alex. I think if we don't see that level of improvement, then those are areas we may have to revisit. But it's not something I'm personally keen to do right now, although I'm interested in views of others around that.
Yeah, thanks, David. Anne, and then Fiona.
So I hope you'll allow me a little latitude, Chairman. David mentioned the pressures that everyone is facing in their daily lives because of the cost of living increases. And we know and have discussed previously, our particular issues here in terms of fuel costs, travel costs. And I just feel it's that we shouldn't leave this discussion without thinking about the difficulties that some of our staff will be facing. So I just wondered if, I mean, we've all heard the media reports, I'm sure, about nurses having to attend food banks and things like that. I wondered if Dave could give us any update on what we were able to do in terms of fuel costs, and not just for staff, but for patients in the patient travel scheme, but also maybe perhaps from Fiona as well about any welfare measures that we have in place to support any staff facing difficulties such as this through provision of help and advice through the Employee Assistance Programme, perhaps, for example. Thanks.
I'll kick off if you like and let Fiona come in behind. So in terms of staff fuel reimbursement, as you know, we're restricted in how what we can do in terms of that. However, government did increase the rate on a temporary basis, which is then extended recently. I top of my head, I can't tell you how much that was extended by. Fiona might be able to. Similarly, we temporarily increased the rate. I think it was 2 pence per mile for patients' travel as well. And again, what we link that to is the HMRC rate. So we're monitoring that rate because it should go up as well, because there's a little bit of a period of time and catch up. And eventually the HMRC rate will go up, and then we'll just default back to that again when it does. But for now, we've got a temporary increase in the patient's travel mileage rate as well. I don't know if Fiona wants to come in on the back of the welfare stuff.
Yeah, and the rates generally nationally went up by 5 pence for the employee agenda for change, and the reserve rate went up by about 3 pence a mile. So that does make a bit of a difference. Yeah, in terms of support for colleagues, obviously we'd encourage colleagues who are struggling, you know, to talk to us and tell us how we can support. Our employee assistance programme does have a very good money advice service amongst as well as legal advice services, etc. And we would be signposting people to that. So I think, and you know, a part of our support offering through you know, kind of occupational health and other channels. Validium also offer counselling through that EAP as well, and not just structured counselling, but you know, kind of advice for people. So we've also got our Wellbeing Wednesdays continuing to run, and we can use that as a way of signposting people to advice and support.
Thank you, Fiona. Any further points for David? Alistair?
Yeah, thanks, Boyd. Just to add on to the point Fiona made, of course, there is a Citizens Advice Bureau, and which is based at the hospital, which takes an awful lot of referrals from staff and from the unions, and provides a very valuable service, and gives money advice, welfare benefits advice, housing advice, and helps people with the energy advice, especially in this cost of living crisis. I think it's managed by quite a reasonable guy, but it does provide a very valuable service to people. Thanks.
Thank you, Alistair. Any further points for David?
Sorry, I did have my hand up previously. Sorry. It was just to come back on the point around, particularly around pay grip and control, and I suppose a bit of context around that, because although we took away that formal extra layer of scrutiny, obviously we do, every vacancy that has to be refilled or advertised goes through a vacancy monitoring process kind of locally, and we have to confirm either where the budget is or that we're confirming a cost pressure there, and I think that probably is the right route for us to monitor wherever possible our kind of cost and spending around recruitment is in local teams, and those local teams joining up to look at, you know, we've just been looking at our workforce plans, and so those local discussions about what are the resource requirements, what are the different ways of filling them, and making sure that we can do that, that's probably the most helpful way, because even in the pressure we're under currently with staffing, sometimes if people we get people kind of concerned they can't make a decision about something because they feel there is a risk there, and what we need to do is, as managers and senior leaders, is support our colleagues to kind of bring forward those questions and to make good decisions about, you know, kind of what's the right risk that we're trying to balance, what support can we give, and make sure that, as well as closely managing our own budgets and running our bits of the organisation almost like they're our own business, but also that we don't miss opportunities, you know, to make a bit of a difference around some of the resourcing challenges we have. So that is a delicate balance, and hopefully we can continue to work in that way so that we can keep that control as local as possible with the right level of oversight from both the kind of directorates and also the support functions.
Thanks. Dave, you want to come back in?
Yeah, it's just a small thing really. In terms of the term group and control was kind of foisted upon us when we were brought into level 4 of the governance. And it's one we all hated and one we all still hate. And I think we do need to come up with a different terminology to describe it going forward. If we do instigate further controls, I don't. It's one that as unfortunate was we inherited, and I think I'd like to change it if that's a parting gift. If I come up with a different terminology.
Thank you, Dave, and thank you for your final presentation to the board. We'll come back to that situation of this being your last meeting before we close the meeting today. But thank you for bringing us the updated situation, and we're being asked to take just limited assurance from the report, given all the variables that Dave has identified. I don't think we could do more than that at this juncture. So are you happy to move to accept Dave's report on that basis? Thank you. And can we move on to the strategic risk register? Is it Boyd or Lorraine that's going to speak to this one?
Thanks, Chair. I'll come in this. So we've submitted a strategic risk register, which we bring regularly to the board and is reviewed also at the Executive Directors Group. We will, a bit like we discussed earlier with the IPQR, I think the risk register, I suppose, is called strategic, but now that we are about to have a strategy, the next step will be to make the transition so that the risk register is aligned with the strategy and therefore the risks against the delivery of that strategy. And so the format will change as that transition occurs. So what we see is a representation of what we've effectively been delivering as the risk register for the past year, and is reviewed regularly. So we've got the practice of bringing it to the board and execs on a regular basis. And where new risks come in or there's a substantial change in a risk, then we will update and inform the board at that time so the board can agree it. I'm not sure if Lorraine wants to come in behind me to say anything. Obviously, as the head of strategy, this is, she oversees it as we go into this new phase, and we're in the process of that handover this time. Happy to take questions.
Lorraine, do you want to come in?
Thanks, Chair. Yeah, as Boyd has described, a bit like what Anne you said earlier with the IPQR, we'll need to review it based on our outcomes approach, and it is just at that transition phase about looking, I think, as we align the data and the quality standards and the financial position, we'll have a much clearer position of each service, and that we will be able to, I guess, look at the risk register with that, but also with the things in mind that we've discussed before, like things that we can't control through the PESEL approach that we'll highlight. So there's, I think, much work to do in this space, but it will come back refreshed in September.
Thanks, Lorraine. Susan and then Gaynor.
Thank you, Boyd, and appreciate what we're seeing here is very much a headline of the, and there's lots more data behind it that has been scrutinised. But I just wanted to understand a bit more about what we've said about workforce capacity, where it's rated as a medium risk for us, because everywhere else we discuss it, it's one of our real pressures. So I wondered if you could give me something about why that's coming out at the medium. Thank you.
I think probably best to bring in Fiona Hogg for this one.
Yeah, and I think to the point that's been made, actually, we're coming into a new way of looking at our risks with the Together We Care strategy, and obviously our our recruitment and workforce capacity is a core element in our planning for that of the strategy. So what we're keen to do is actually to reevaluate the risks that we have sitting around the workforce at a corporate level, and as sort of score and assess them based on where we are now and where we'd like to be as a result of obviously the sort of first delivery of the ADP until the end of 2023. So I think that's one that we didn't revisit it at this point in time, because we know we're about to refresh those risks. But I would anticipate that what that will allow us to do is to be more specific with that risk as well, and potentially have have more granularity in the risk so we can assess it. But I think it's a good point, and as we look to restructure those risks ready for the next report, we will be bearing that in mind.
Thanks, Fiona. Gaynor.
Thank you, Chair. Apologies, I'll have to leave at 1 o'clock to go to an appointment, but I just wanted to say that at the Clinical Governance Committee, when we last met, we reviewed our strategic risks, so I thought I'd feedback on those now, if that's okay. In terms of the strategic risk 662 around clinical strategy and redesign, I can't tell from the text that we have here in front of us, but the committee really wanted to say that this doesn't really sit with the Clinical Governance Committee. It originally sat with Clinical Governance Committee when it was a clinical strategy, and so the recommendation really of the committee was to give that back to the board for overall scrutiny rather than Clinical Governance Committee. So because I can't see that in the text there, I'm not sure if that's been done. And just to update on strategic risk 715 and 959, both the public health risks. So the committee agreed that the EGG be recommended to reduce the current risk level assigned to risk 715 from very high to high, and I see that's already happened there. But we also agreed to maintain the risk level assigned to risks 959 as high, but I see that's now down. Sorry, I'm jumping from one page now. I can see that's now down at medium. So I just wondered what the rationale was in terms of the public health risk around vaccinations being now at medium. Thank you.
So I'll come in the first bit. I don't know if Tim's here, he may wish to comment on the vaccination. If not, I can speak. So the next step, exactly as Gaynor said, and it isn't in the text of this document as the next step from Clinical Governance Committee's discussion, and a feeling that I was strongly in favour of as well, that actually it's more than just a clinical strategy. The strategy is a very wide and holistic one, of which clinical is part of it, and Clinical Governance Committee has a very real invested interest in most, if not all, of the strategy, but it's not purely a clinical strategy, and so it should be a board. It's a board risk that if it doesn't have a strategy, it clearly does. It should hopefully next month ratify it. So the next step from that discussion is that the Risk Management Steering Group will look at that and make the recommendation as well, and that's due in the next meetings, I think about the 17th of August. So we'll feed up through that, and hopefully by the next board meeting be a definite proposal and request for the board to endorse it as well, and then the board would assume that responsibility for that one after that. On vaccination, I don't know if I can see Tim there. If you're there, Tim.
Yeah, I'm here, fine.
Thanks. So the question was about the level of risk assurance for delivery of the vaccination programme. Thanks.
Yeah, I mean, I think the risk level reflects really what has been covered within the vaccination paper earlier. There are still risks in terms of both finance, although the finance risk has been down, is less than it was, and risks for staffing. We do keep this particular risk under regular review through the Clinical Governance Committee, as Gaynor has commented. I think at the moment, I think it's appropriate to have a medium risk, but probably within the next, certainly within the next quarter, we should be better placed to know how the risk is working out in terms of both VTP implementation, and we'll be then well into the delivery of the COVID and flu vaccinations in the autumn. So we may well then look to downgrade it.
Thanks, Tim. Did you want to come back on that, Gaynor?
Thanks. No, it's just that I just queried that the 959 as in our minutes we say the risk assigned to that was high, and it's now down at medium. So I just wondered what had kind of happened in the interim, but maybe we'd made a mistake in our Clinical Governance Committee meeting, and maybe it was medium. I'll need to go back and have a look at the papers. Yeah.
Okay, thanks, Gaynor. Anne?
So just in a similar vein, I suppose, sorry, I'm conscious that earlier in the meeting, we accepted limited assurance around the paper on our performance. So it was, David at the time clarified that the annual delivery plan, which we'll see in September, will contain trajectories addressing many of those areas of performance. But I suppose I was also wanted to suggest that at the meeting that Boyd has mentioned, that the team consider whether the risk level against 1, 2, 3 should remain at medium. Thank you.
Thanks, Anne. Alistair?
Yes, thanks, Boyd. I think that the report acknowledges how pivotal the role of the risk manager is to this. And I don't know, Boyd or Fiona, if there's any update since the paper was authored as to what it's looking like in terms of recruitment. Have we got many people applying? Is it what we're looking for? To give us some feel around how the success of the recruitment exercise is going.
Yeah, so I'm probably not right to say a board about numbers of people applying for jobs, so I won't do that. But I'll just say that the process is ongoing, and it's just fixing the interview date has been the current challenge, and I'm hopeful that will happen very soon, so that we can progress. Undoubtedly, we shouldn't pin hopes on the appointment of one person. It'll be a collective effort thereafter, and in the interim I've been making some extra linkages with there's a growing national risk sort of network for the NHS, which I've become aware of, and I've made initial contact with that. So so we will update board as that progresses.
Thanks, Boyd. Alex?
Yeah, just a couple of things to build up what Anne said. I think at the next FRP committee meeting, we'll certainly look at the finance risk and the performance risk. I think both of them may be recommended to go up by us. That doesn't mean to say that recommendation will take on, but I would suspect that finance may go up to very high, following the risks that David and the discussion that we just previously had about some of the financial issues, and the performance possibly high too, as Anne said. Thanks.
So we have a mechanism to make these adjustments before our next meeting. With that in mind, are we happy to take a substantial assurance from the report? Yeah, thanks. And we're due to move on to a number of items on governance at this point. Conscious also that we're past the lunch break. I don't foresee that the rest of the agenda is going to take that long, and I was going to suggest that we might progress with some items just now and see how we get on. Yep, I see some thumbs up. Tim, did you want to come back in on that?
Yeah, sorry, Chair. Just taking a little bit of time to find them. Just returning to the last agenda item, and I've just checked up the paper from the Clinical Governance Committee about the risk levels on risk 959, just for the record, and the recommendation was to keep 959 as high. So 715 was reduced to high, but 959 was remained as high. So we just need a slight modification on that paper.
Okay, thanks for the clarification, Tim. Can we move on then to the blueprint for good governance, the improvement plan, and in Ruth's absence, Nathan, did you want to add anything to what's already in the paper, or to highlight anything in the paper?
Yeah, just to kind of highlight, so it's an update on the blueprint for good governance improvement plan. It was originally brought to the board in April 2019, and progress was last reported in September 2021, and it's been considered by the EDG team as well. So it's just to take assurance on the significant progress that's been made with the engagement framework, agree on the closure of the 2019 blueprint for good governance action plan, and to note that there's discussions underway for an independent external review of the board's governance to be undertaken following the publication of the next iteration of the blueprint for good governance, which is expected later this year. But happy to answer any questions.
Thank you, Nathan. Just on that last point, the next iteration is due imminently, and that's part of the reason why the independent external review is going to be delayed. It was thought best to have the independent review in the context of the new version of the blueprint. Any questions? If not, are we happy to agree to take assurance from the report, and that we treat this now as an item that's being closed? Thank you. On now to item 11, which is governance committee memberships, and Ruth has prepared a paper for us on that. And again, Nathan, do you want to highlight?
Yeah, not much to add, fairly straightforward, but just to approve the revised governance committee membership. So those are highlighted in your papers, and that's with the two new non-execs that joined us. Also to note, the Highland Health and Social Care Committee must now appoint a vice chair from its membership, and also to note that a formal approach from the Highland Council is awaited to request board appointment to their Health, Social Care and Wellbeing Committee. And that one's moderate assurance as well, sorry.
Thank you. And did you want to say anything about the Highland Health Social Care Committee or the Highland Council situation?
Well, on the Highland Council situation, I believe that Ruth has raised that issue with them, and so my understanding was that there would be a paper going to the council on membership of outside bodies. So we await information on what the recommendation might be in relation to that committee. and in terms of the vice chair, I'm in discussion about that. It's been a little bit held up because of Philip's absence due to his accident. So,
yeah,
because I wanted to have discussions with all the committee members before taking that forward.
Okay, thank you. So essentially, the paper is making appointments, formalising the appointments of Muriel and Garrett to various committees, and acknowledging the fact that there is still to be a vice chair appointed for Highland Health and Social Care Committee, and we're awaiting an approach from the Highland Council as to their Health, Social Care and Wellbeing Committee and what representation they want from us. Are we happy to approve of that and take assurance from it, moderate assurance? Thank you. And the next item is the Gaelic Gaelic Language Plan Monitoring Report. If you recall, as happened last year, in fact, this was required to be submitted early in July in meetings of the board, and Pam and I were authorised to submit it on your behalf. And Pam, you mentioned that you had received approval from Port Gaelic.
Yes, via Nicola, we had an email that said that had been approved.
And we will be required to develop a Gaelic language plan in the coming financial year. Fiona.
Yeah, and it was just to, I think it's set out in the report, but just to confirm that in line with our sort of making sure that everything that we're working on that's a core priority for us fits within our Together We Care strategy and the annual delivery plan. This does form part of our Thrive Well area and particularly around our inclusion. So we'll be taking that forward as a key part of that. And obviously just also wanted to give our thanks to Nicola Thompson, our Gaelic advisor, who has been promoting and driving this forward for us. And I think we've seen a sort of big increase in terms of our activity and our promotion around this. And I think the support of the kind of ADP and the strategy approach will help to kind of make sure this is part of our mainstream planning going forward.
Thanks, Fiona. Susan.
Just a very quick thing. Where does this place us? We've seen this report. I mean, what does it say about us as a board? Are we doing well or are we not doing very well?
I think the answer to that is there's much more we could do. Unfortunately, we didn't have Nicola's services for the full year last year, and that certainly affected the activity levels. But she's back in full harness now and very, very active, in fact. And I would expect to see quite an uplift in activity in the coming year. Anne.
So when I was reading this report, particularly in relation to the issues around recruitment, it just struck me that I wasn't sure what the situation is in relation to both the skill set and the promotion of non-executive appointments to the board. Obviously, we're in a good position at the moment, courtesy of our chairman. But you know, I thought perhaps that was an area worth exploring, as obviously perhaps as a desirable skill, but at least in the promotion of the adverts, I thought we could do something there if we don't already. Thank you.
Was that in terms of non-execs at that point? Yeah, I think that's a very good point, and one that we can take to the Scottish Government for the next round of appointments. as you say, as a desirable skill, and it's the same for other public boards. There's also an issue that we've identified around the logo for the board. There seemed to be a barrier to having a bilingual logo for the board, despite the fact that the Western Isles Health Board has that already, and it's something that Pam and I have raised with the Director General and the Cabinet Secretary, and their personal views were that they could not see any reason why we wouldn't have bilingual logos for NHS Highland. So Pam is following up with the Director General about that. So just back to your point, Susan, I think there is need for more development, and the development of the Gaelic plan itself will provide scope for that.
Happily.
Believe that. With that in mind, we're just being asked to note the terms of the submission at this point. We move on then to item 13, governance and other committee assurance reports, and any escalation of issues from the chairs. Alistair from audit.
Not too many things. I think a lot of you were there because it was combined with the annual accounts. I know a lot of you were there, but there was probably two very interesting reports that were considered, so I would urge the people to read if they haven't already done so. One was the internal audit report on unfilled shifts, which is going forward to other groups and committees to look at, and the other one was relating to home working. And again, that will probably be surfacing in other places. But if colleagues haven't read those two internal reports, I would well suggest that we find them very interesting and informative, and would perhaps help shape some of the issues that they're facing on their committees. I think other than that, Boyd, there's nothing. I'm quite happy to answer any questions that anyone might have.
And just to recognise that that was the last meeting with our external auditors, our current external auditors, and there'll be new external auditors appointed. Clinical governance, I know that Gaynor had to leave the meeting. But
yeah, I'm still here, Chair.
Oh, hi, Gaynor.
Yes, thank you. I've already raised what we discussed in terms of the risk register. I think the other discussions, it's very stark and well laid out in the minutes. We had a number of other discussions around patient safety and quality, and how our services are running, and the pressures on those, as Boyd and Pam have both outlined at the beginning of today's meeting. So there are many things that we've been informed about. They're clearly laid out in the minutes. I don't know if Boyd wants to say any more, but obviously many of these things are not going to be fixed overnight. They're long-term issues, as Boyd and Pam have already outlined. So the committee is aware of them, and board members can see them in the minute. The board as a whole are aware of them, recognise that they're there, and are trying to work to resolve these as best as possible to increase patient safety and the quality of our services. But as I said, I think we all acknowledge that that's not going to happen overnight, and there are many things mitigating many pressures on the system that make it difficult. So I'll leave it there and maybe hand over to Boyd if Boyd would like to say anything else.
Thanks. No, I had a good airing at the start, Chair, and I don't want to repeat myself, but I think Gaynor has usefully touched on it again, and the Clinical Governance Committee does look at the safety, the patient quality as well, So it has a strong remit in overseeing this activity and these challenges.
Thanks, Gaynor, and thanks, Boyd. Anne, Highland Health and Social Care Committee.
I think likewise, in terms of this committee, the pressures that we were talking about earlier are fully reflected in the minutes. And as Pam said in her own presentation, it's an issue that very much affects community services and adult social care, as well as our hospitals. So as with Gaynor, I think the minutes make clear that we had a good discussion about a number of the key pressures, both recruitment and finance, that are being felt in our area of responsibility. Thank you.
Thanks, Anne. Moving on then to Alex, Finance, Resources and Performance.
Thanks, but nothing to escalate, but a couple of areas to touch on that we haven't touched on today in the board. The states and the report we got from them on major projects, updates, that's all very positive. It's going well. We had a discussion on the proposed performance framework, and Lorraine brought that forward. And I think once that is instigated and beds in, I think we'll see the benefit of that over time. And Ian Ross gave us a report on the digital strategy for 2022-23, and that went that was good. And it's something that I think we'll get it every 2 or 3 months, but it's something that perhaps we want to think about for the board in terms of perhaps something for a development day. Thanks.
Thank you, Alex. Area Clinical Forum, Katrina.
Thank you. Yes, similarly, I think a lot of our key issues with regards to workforce pressures in both health and social care have been touched on by the board this morning and recognised fully. So I've got nothing really to add extra on that. I would just say that we had a very constructive discussion with regards to the leadership and management development that's being run by the board. Everybody was very engaged with it, and I think it's we used it as a route to try and encourage that message to be taken to the professional advisory groups, and we'll be trying to encourage that on an ongoing basis. But it was a very open and good, productive, positive piece, actually led by Caroline. So thanks to Fiona for having Caroline along to talk to us.
Thank you, Katrina. Staff governance, we don't have minutes, but we're getting a verbal update from Sarah from a recent meeting.
Thank you, Chair. Yes, we just had our meeting last week. Unfortunately, due to some unforeseen absences, colleagues, we weren't quorate at the meeting, but we still used the time as an opportunity to get an update on a lot of the kind of rolling issues. So we had some good discussions there. We had already slimmed down the agenda for the July meeting, just given that lots of people are on leave and it's quite a difficult time to get people around the table. So Fiona and I have made sure that any items we weren't able to approve will come back to the next meeting. And as I said, a number of the things we discussed were kind of rolling items anyway, but it was a good update opportunity.
Thank you. And you're still on for the Ijb report.
Sorry, yeah, me again. So the minutes you see before you for the Ijb, it's a little while back. It's from the end of May. Nothing to escalate, but just to draw to people's attention, it was our first meeting with our new elected members from the council, and a couple of important business items went through, including a positive provisional year-end financial position and also the approval of our strategic plan for the Health and Social Care Partnership in Argyll and Bute. And we have another Ijb coming up in the not too distant future, and I'll bring an update from that one at the appropriate time. Thanks.
And you have a new vice chair. as a result of the... Yeah.
Yes, I do, Councillor Amanda Hampsey.
Thanks. Any questions on any of these reports? And does anybody want to ask anything about any of these reports? If not, can we confirm that we take adequate assurance from the Governance Committee minutes and note the minutes and agreed actions from the Clinical Forum and the Ijb? Are we happy to do that? Okay, thanks. Is there any other competent business? Noting that the next meeting is on the 27th of September. Before we close then, there is one other item of business, and that is that this is Dave's last meeting as Finance Director of Finance, and we can't let that pass without marking it, because Dave has performed wonders in that role. I know that I've found Dave personally a very reassuring figure. He's very realistic and very grounded in all the presentations he gives and the advice he gives us as a board and to committees as well. And he has been a really reassuring presence around the board for the time that I've been chair. And he brings tremendous wealth of experience and knowledge to the board. He's got a huge amount of institutional knowledge. In fact, you could describe him as an institution himself. And he will be greatly missed. He's a huge asset to NHS Highland, having been working in the board for so long. He has vast knowledge of the operations of the board and knows people throughout the Highlands area, Argyll and Bute, through the Ijb as well, very, very well indeed, and has considerable knowledge of special areas like the adult social care one and the integration model in the Highland Council area. And we are going to miss you, Dave, at numerous levels, at the professional level that I've just mentioned, but also at the personal level. We will miss your contributions to the work of the board, to the deliberations of each of the committees of the board. I gather that you had some presentations last week and that you're now kitted out for all these foreign holidays that you are about to go on. But I just wanted to thank you from the board, on the board's behalf, for your commitment to the work of the board and for the sage advice that you've been able to offer us over a period of many years, and how much we value you as an individual as well as being as a professional. So thank you very much indeed, David, and I'm sure other colleagues will join me in expressing that gratitude to you.
Thank you very much, boys. Thank you. I have to say it's been an absolute privilege, and thanks to everybody for the supports. I think I'm leaving in a safe pair of hands. I think we've got a really strong exec team. Highland will thrive, and I'll be a figment of your imagination in no time, a distant memory. But thank you very much.
You'll be able to send us postcards. Okay, thank you, David, and
thank you.
All the best in the years ahead, and you'll no doubt keep in touch with us and follow the financial fortunes of NHS Highland. Okay, thank you, and with that, bring the meeting to a close, and we'll reconvene at the end of September to discuss the strategy, the annual development plan, and a whole host of other matters as well. So, thank you all.
Thank you.
Thank you.
Bye, folks.
Bye.